Thank you. I'm Dr. Ganguly, and this is Dr. Halder. We'll be giving you a very brief present summary of what has happened throughout the day. I will ask Dr. Halder to go on with the pre-lunch session.
Um, Thank you, Hugh, and a very good afternoon to you all present so far. I'm going through the programs this morning. First of all, after we started, there were a bit of a change in order, but I'll go through the sessions gradually one after another. We started with a session Mr. Havel did on basic safety issues. Like he has emphasized on the importance of ATLS, which is of prime importance to all the surgeons and everyone practicing in the field of surgery. And so followed by a session by Professor Peter McCallum. It was on orthopedic and vascular surgery. The issues we have discussed, the safety issues we have discussed, especially on prevention, decision making, procedure, and information issues. So we have addressed a few things like we discussed on a patient with a knee injury, vessel injury during a total knee replacement. It was about the tourniquet, time for tourniquet release, and the decision of the surgeon, and the change in position, the various issues about that regarding the intraoperative angiogram, the procedure, what we should do, whether we should anastomose directly or we should use some prosthesis, and there was an issue about the venous bleed, how to tackle it, and most importantly, post-operatively, what should we say, tell the patient. And in the session, like what we've eventually gathered is it's of the major issue was very important to make a decision by the surgeon, take every measure to save the injury to the vessel, and then time intervention in a timely manner, and subsequently it's the most important thing we found was the communication to the patient to prevent any further major damage to the patient and the surgical team. Subsequently, we had one session on minimal access surgery by Dr. Ramesh Agarwala. We have been through a few situations, and briefly, the issues we have addressed is one is the access. First of all, access. The audience was a bit divided about the use of an open port or closed entry, but consensus was possibly a safe entry would be an open port method. There were some issues regarding some people had quite a bit of worry about the use of closed technique in the presence of a hostile abdomen. And there were some situations were discussed about a situation about trocar in the stomach, what we should do, and other few things like bile coming through the drain. So all these issues were roughly touched, and we reasonably covered some of the very common safety issues during the minimal access surgery. Then there was another session by Professor Batra on behalf of the National Board. We have had an elaborate discussion on various issues like training issues, the structure of our training program, and he has very nicely overviewed the whole situation, and there was a bit of a comparison with our system and the system in UK and how we can benefit ourselves, and he also highlighted the challenges in front of us, especially for the trainers in terms of producing safe surgeons. And he also, at the end of his discussion, he has given some thoughts about the way forward. He also discussed about the assessment process, for the postgraduate trainees. Now, this session was followed by an oncology session. We have covered issues regarding breast surgery, colorectal, and thyroid surgery. Regarding the breast surgery, a few issues, mostly touching on the content, like the general feeling and the evidence. We have touched on the LABC. One situation was on LABC about the evidence regarding mammography, FNSC, and then the choices for the patient, what operation we should offer regarding the nurse navigator, and a few other issues regarding the course of neoadjuvant chemotherapy, how many cycles we should give, what is better to follow the patient in terms of the response to the neoadjuvant chemotherapy. And we had attained some consensus decision regarding this, like mammography is a must, there should be no doubt about it. FNSC, although is quite frequently done here, but we should always give importance to the trocar biopsy is a mandatory. Choice about the surgery for the patient, we leave it to the patient, especially in terms of the nature of surgery we should do. There has not been many issues regarding the neoadjuvant chemotherapy. 3 cycles chemotherapy is possibly better according to the audience and the chairpersons. There were some innovative method suggested by Professor Chintamani to locate the index site in case the tumor shrinks quite a lot or disappears for future surgery. Safe surgical margins. Well, we had some discussion on it. We should maintain a safe surgical margin. Regarding thyroid, we had some issues, especially hemithyroidectomy, and the general mood was for a total thyroidectomy, even for a small thyroid cancer. But eventually, Dr. Chintamani has told that from the discussion, it appeared that for favorable tumors, we can go for hemithyroidectomy. There were some issues from the nurses, but discussed as well. Regarding radiotherapy, although there's not been many evidences regarding when we should give radiotherapy or not, it's been eventually we found that possibly anything less than 3 centimeter may not require further radiotherapy. Regarding rectal cancer, most of the people were hesitant to do low anterior resection, and almost everyone decided to go for protective ileostomy for a low anterior resection. These were and there was a brief session of pediatric surgery, and a few issues and certain situations were discussed regarding hernia, torsion, and umbilical granuloma. There was a nice demonstration of a case of umbilical granuloma where we often attempted to cauterize, but Professor has told that Professor Gupta has told that possibly we should not do it, and that was demonstrated very well by the case. So with this, we moved on to the lunch session, and after that, I was possibly feeling a bit dozy. So Shuvra has collected the data to sum. Thank you.
We had a few brilliant sessions from the morning on surgical aspects, various safety aspects in surgery in different fields, orthopedics, vascular, GI, pediatrics. Had covered a lot, but probably the star session began in the post-lunch when Professor Hegre not only redirected blood flow from the splanchnic circulation to the central nervous system, but also the issues, the directions from medical science to philosophy. He gave us directions to look for answers where the answers were not clear. He told us absence of evidence is not evidence of absence. That was probably the line which struck me most today. He told us science is faith, that common man has the ignorance. Common man has faith in the ignorance of the expert. So I believe that was a wonderful session that was followed by Professor Tomanas Chaudhury's session. Again, back to physics, a little apart from pure medical science on energy source, monopolar diathermies, bipolars, intelligent diathermies, and the ultrasonic machines. We had gathered quite a few knowledge on that. But all we learned was that we must have a scientific mind which is aware of the available knowledge, and we should stress importance on adequate training and diligent implementation of the available safety protocols and practice, which is of paramount importance to avoid the so-called bad luck. We should learn from mistakes and preserve the ability to question just bad luck. Finally, Professor Hegre has enlightened us on the ability to retain lateral thinking and to accept the unknown. Thank you, everybody.
Just, I do profusely apologize for this was not deliberate actually. The sessions were quite changed. So, Mr. Ricci, he has given the most notable lecture today about the WHO safety checklist, and it was the most important lecture in the session, I felt. So I thank every speaker and the chairpersons and everyone in the audience for making it a very enjoyable session. Thank you very much.